Good afternoon, good evening, good morning. My name is Simone Carter. I am the lead on integrated multidisciplinary outbreak analytics for UNICEF's Public Health Emergencies team, and I run the Social Sciences Analytics cell in the DRC. So today I'll share with you a little bit about our experiences from the key results on data used on vaccination during the 10th and 11th Ebola outbreaks in the DRC. Talk a little bit about how we've adapted these questions based on learning from Ebola for COVID for DRC household and healthcare worker surveys, and present some of the results from the most recent healthcare worker surveys that we've conducted in January 2021 and how these can be used, and just summarize with some guidance on better use for social sciences analytics and vaccination in humanitarian settings. Just quickly first, a little bit about what is the Social Sciences Analytics Cell. So we were set up in September 2018 at the beginning of the Eastern DRC Ebola outbreak to provide real-time operational analysis to better understand outbreak dynamics. So the team sits together with epidemiologists. We bring in DHS2, so health services use data analysts as well, to understand not only differential trends in outbreaks, but also understanding the broader impacts on health and health outcomes. Since the Ebola response, we have been set up to support the Ministry of Health in multiple outbreaks, including cholera, COVID, and following Ebola outbreaks in EQUATEUR. We also support this approach more globally, working through GOARN, so the Global Outbreaks Alert Response Network, and UNICEF global teams to support this kind of approach in future outbreaks. We have 5 key objectives: conducting rapid research, rapid analytics to better understand the outbreak dynamics, providing this evidence in near real time, so anywhere from in the Ebola outbreak, anywhere from 2 to 5 days. Oops, sorry, my screen hopped. To really support actors in the use of data, so making sure that we don't just collect data and write reports, but that we're presenting that data, that we're working with actors on using it better, helping them set this up, helping them co-develop actions, and monitoring the use of those actions over time. We create a space for what we call the integrated multidisciplinary outbreak analytics. So this is about bringing together data sources, EPI, DHS2, social sciences, markets analysis, to really understand both the dynamics which drive an outbreak and the impacts of the outbreak itself. We work through national researchers, and we have strong partnerships with national institutions to really build the capacity for this integrated multidisciplinary approach in outbreaks across the country and others. So looking a little bit about the data from the Eastern DRC Ebola outbreak, I think just one very important thing to say is that during that outbreak, the vaccination was rolled out as a trial, so for compassionate use. So this meant that there was use of consent forms, and the word trial and experiment were repeated throughout the outbreak, which of course created a different perception of a vaccine in and of itself. So this data, we've been asked to, meta-synthesize and summarize some of these results for multiple times. So what we've done is taken across all the different 14 CASS studies, which covered 3,061 individuals, including household, healthcare worker, and qualitative studies from the Eastern DRC outbreak. And in EQUATEUR, looking from June to July 2020, covering 117 out of 189 healthcare facilities, and household surveys, which covered 7 health zones, covering over 2,000 individuals. So summary of the results from North Kivu. What we saw in terms of main perception, community perceptions, was that about half or more of community respondents reported that since Ebola, they became afraid of vaccines, for all vaccines for their children, fearing that children would be infected or would be receiving an Ebola vaccine. 46% in Beni, so in the hotspot area, reported that people refused the vaccine because of the misunderstanding of eligibility criteria. So the ring vaccination was very hard to understand and very poorly communicated. 23% of community members reported that people refused the vaccine because the information about the vaccine itself was not clear enough. From healthcare workers, we saw that 42 to 55% reported that they wanted more information about the vaccine. So this wasn't just a community issue, it was also a healthcare worker issue. In the epicenter, so in Beni, 21% of healthcare workers had received training. So really an insufficient amount of information going both to communities, but also to the healthcare workers who are supposedly the points of information for such such information. 65% of healthcare workers reported that communities refused the vaccine because they were scared of the side effects. So when we looked at the EQUATEUR data in 2020, so almost 2 years later, although the majority, so this was, there had also been a previous outbreak in EQUATEUR in 2018, then it moved, then there was the outbreak in the East, and then again in EQUATEUR in 2020. So this is the second outbreak in the 2 years in this region. And so 83% reported having known the vaccine, and the majority said that they felt that it worked. However, 49% of healthcare workers had not been vaccinated against the vaccine, the majority because they were scared of the side effects. So similar to what communities were, or healthcare workers were fearing communities to say in Eastern DRC, was the same reason that healthcare workers in EQUATEUR were worried about the vaccine. As well, a large proportion, so 18%, still did not know where to get vaccinated, which also indicates, again, a lack of communication and explanation about the process for vaccination. So in terms of community data from EQUATEUR, again, the majority had heard about the vaccine, but almost half would reported not being willing to get the vaccine if it was offered. The biggest reasons for refusal were about not trusting the vaccine, fearing that the vaccine would infect them with Ebola itself, or believing that Ebola was not in the area, not trusting healthcare workers who were providing it. So a key summary of the different qual and quantitative data. Number one is that there wasn't a lot of improvement over the 2 years in terms of vaccine perception and trust. The misunderstandings largely stemmed from a misunderstanding of side effects and the eligibility strategy. So ring vaccination, the changes in eligibility for pregnant breastfeeding women, and a lack of clear communication about that. So what we see on the big poster on the right is we really pushed to accept the vaccine, but it wasn't something that was actually available for everybody. And so the communication about who would receive the vaccine and why was never really clear. There was a distrust because there was a lack of understanding about how it worked. So over the 2.5 years, there was no communication materials that explained how the vaccine actually worked in one's body. Again, that the vaccine was promoted but not provided for everyone, that the healthcare workers used to administer the vaccines were not the same healthcare workers administering routine vaccinations, that the vaccines were conducted on unusual locations, so in tents outside of healthcare facilities. Often there was presence of police, and that the ethical clearance forms that were required were often in French or academic Swahili. So there was an issue about a lack of trust as well of those who were providing the vaccine, and a perception that healthcare workers did not have sufficient information to talk about the vaccine and respond to questions. So how we've adapted the questions based, how we've adapted the questions based on learning from Ebola for COVID. So one of the things really important to be conscious of is that vaccine perceptions data can actually be quite dangerous. Often we say, would you accept the vaccine? And then we make blanket statements about communities saying 40, 60, 50% of X population wouldn't accept the vaccine, which immediately paints them as negative, defiant, hesitant, without understanding what are the factors that would build trust. And so we're not creating actionable interventions or actionable data. It becomes difficult to understand the causes of a perception. So if you wouldn't accept something, why? And you know, what are the driving factors behind a distrust? There's also a lack of nuances at community level. So I've seen recently some reports saying X percentage of women wouldn't accept the vaccine. Except, is that a policy issue? Is that a pregnancy and breastfeeding issue? Is that an eligibility issue? Is that a communication in that area that has specifically not targeted a particular group? So we also have to be mindful of how this goes against policies and needs to be location and nuance specific. And so we want to have campaigns that are focused on understanding of barriers rather than just focused on pushing acceptance. And so how to make better use of the data. So what we've done is, first of all, mixing qualitative and quantitative data. So making sure that we're understanding perceptions, causes of behavior or perceptions, and the options to action and address this. So what are the factors which fuel distrust of a vaccine and how we can address this better? And that takes mixed methods. We need to be asking action-oriented questions. So if we know that the vaccine is going to be rolled out, it's not as important to understand if you would accept or not, but what information do you need to feel trust in the vaccine? Who do you need that information from? And those are things that we can then action later on. ensuring that the key data users are involved in the survey and study development. So I think there's often a disconnect between the inclusion of those who will make decisions. So are those healthcare workers? Are those the Ministry of Health? Are they NGOs? Are they the UN? Are they, local level health authorities? And so making sure that those individuals are involved in the study development, that they're telling you at what level they need the data, at what granular level they need it to be able to make a decision, and what kinds of questions they could use to be able to better make their decisions. And of course, making sure that we're not just looking at COVID-19 alone, that we're really looking at broader impacts of the dynamics with all vaccination. So are we seeing impacts on trust in other vaccines, impacts on uptake of other vaccines as well? And so just sharing some results from the healthcare worker surveys that have been conducted just last month in KINSHASA. So when we asked, first of all, how confident would you be in the new vaccine if it were available? And this is scattered between moderately, a little bit, very, and not at all. We asked specifically, what are the fears and concerns about the vaccine? What this allows us to do is to really then focus on communicating around those fears. So again, we see the issue of side effects. So how are we clearly communicating on side effects of vaccines and how the vaccine works and what it feels like? We also ask what information is required. Again, we know that the vaccine will come. What we want to understand is what are the concerns, how we can address them, and what information needs are required to do so. And so again, we can then develop communication strategies with the risk communication, community engagement, but also trainings for healthcare workers, trainings for NGOs to better communicate with healthcare workers, et cetera. So here we are seeing the importance of talking about how the vaccine works, how long it lasts, real details and granular information. And this is something that we really missed in the Eastern DRC Ebola vaccine rollout, was a lack of communication on those kinds of real details of how the vaccine works, who is eligible, et cetera. There are much better tools for the COVID vaccine on exactly that. So we also need to know who would they prefer the information from. So we know now that it's medical leaders. These are government medical leaders from the Ministry of Health. So it is important that these are the people who are communicating on the key questions that are asked. And so when we think about guidance for better surveys, better social sciences evidence on vaccination, one of the things we need to think about is repeating surveys over time. So are the information needs being met? Is the type and the source of information being responded to based on what we're seeing in the studies? We need to make sure that we're presenting the results across all of the actors. So in the DRC, we work across commissions, we have risk communication, IPC WASH, but we also need to be working through Ministry of Health, NGOs. Everybody needs to be having this information repeatedly so that they can make decisions. We need to track that decision-making process over time so that we can demonstrate the use of evidence and its impact, hopefully positively. Making sure as well that we don't just stick to surveys at a large scale, that we really are clear about qualitative studies at a granular level. Something else is that we make sure to track this over policy events. So when there is a specific Minister of Health communication, or when there is a rupture in stock of another vaccine or border closures, how do these kinds of events on a timeline impact community perceptions and trust and engagement with a vaccine? So we need to take these nuances based on these kind of events as well. And qualitative studies can help us do that. So everything that CASS does are tools, raw data, tool formats. We use Cobalt Collect for the household surveys, and everything is available online. It's open access, so it's really, we operate as a service for different response actors. So you can either get in touch or click on the drives, and feel free to access anything that can be useful to you. And I'm available for questions. Thanks very much.